we'll start out by reading the cards. So the first, just take them in order that they came in. Do you know of any possible valid uses for stem cells in MSA now or in the future? So that's, Larry, do you want to take that question?
Okay.
And then Amy Coulter this afternoon would be another person to answer this question as well.
The question is, what at present is the role of stem cells in treating MSA? It's certainly not ready for prime time in MSA or any other neurodegenerative disease, keep in mind that if you're talking about replacing lost cells, that's going to be very difficult with stem cells because there's so many areas where there's cells lost. You can't just implant stem cells in so many different parts of the brain and spinal cord like you might be able to if there's a stroke or a heart attack or something. But where stem cells will be the most useful first would be as drug delivery vehicles, because stem cells can be programmed to produce whatever you want them to produce. Just like right now, diabetics take insulin which has been made by bacteria that's been programmed genetically to produce human insulin. A human insulin gene is put into bacteria, and in a dish, the bacteria are busy churning out insulin. You pour off the insulin, and that's how we get insulin. Well, a similar thing could happen with stem cells. They could be programmed to produce, say, dopamine and implanted into the brain, and the dopamine can then be used as if you were taking it by mouth. Other things that stem cells might be able to be programmed to produce are trophic factors, which are proteins that help brain cells grow. And the trophic factors could spread through large areas of the brain and help brain cells to regrow or at least not to degenerate. So those are the two main things that might be useful, that might come to pass in the near future.
Thank you. Here, we have a question from the audience here.
Oh, gosh, I thought I'd have to wait till the cards were done. We have some concerns in terms of our own children who are now approaching the point in their life when they're going forward and having children. And so I have some concerns about the genetics of MSA, which my husband has, and any advice that we can give to our children.
So there's really no evidence at all that MSA is a genetic disorder or is passed. So I think you could be pretty confident in saying that that's very, very unlikely. There are very occasional reports, but the diagnosis has been questioned. There are genetic studies looking at MSA, trying to understand what genes go into, what genes predispose a person to MSA. But I think that it's one of these disorders where you can be very confident that, at least to the best of our current knowledge, there is really no genetic component. Do you agree?
We'll kind of alternate between the cards that were the questions that were written. So if anybody else in the audience has something they did not write, just raise your hand, and either Vera or I will come to you.
Let me just expand that answer that Tom said. When he said that there are genetic studies that have shown genes that may contribute to the risk of MSA, what he meant there is that there is a variant in the alpha-synuclein gene, which is a little more common in people with MSA than in the rest of the population. But the fraction of the risk of MSA provided by that variant is tiny, so tiny that it's not going to show up in increased risk in the children of people with MSA. So for all intents and purposes, the children of people with MSA don't have any greater chance than anybody else.
Thank you.
All right, so we'll try to alternate the questions so that the three of us have a chance. So let's read out a urologic question. You've got a ton here, so why don't you pick which one you'd like to answer?
So one of the questions is, what alternatives can you offer for bladder retention due to infections after catheterization? So basically, if you recall my presentation, there are three main reasons why you can have retention of urine. So the treatment is always directed towards the cause, like anywhere else in medicine. So for example, if it's a weak bladder, you need to either empty the bladder physically with a catheter, either by inserting a indwelling, like 24 hours you have the catheter, or self-intermittent. Or you can insert a catheter through the belly. We call that suprapubic, through the belly. So if you, the incidence of infection by doing a self-intermittent catheterization is somewhat uncommon. I mean, there can be variations, but somewhat uncommon when compared to keeping the catheter all the time. So, and also, what we do is we keep the patients on what's called methylamine. Methylamine is it's not an antibiotic, it's an antiseptic, urinary antiseptic. What it does, it releases a chemical called formic acid in the urine. Formic acid, which just kills the bacteria. This is very, very important. It is very effective. I have a lot of my patients on this medication, especially when a patient is on either self-intermittent catheterization or indwelling catheter or suprapubic, any of the catheters. When you have something foreign body inside the bladder, we keep the patient on that in addition to a low-dose antibiotic. This also will reduce much more the incidence of infection. For example, if the retention of urine is because of the prostate enlargement, obviously you have to treat the prostate. And if you still have a lot of infections in spite of doing all this, taking all these measures, then what we do is called suprapubic tube, because the incidence of infections is much, much less with the suprapubic tube compared to keeping the catheter through the urethra. That is one. And then, so if you have to really know what is the reason for the retention of urine, and then you can get a better answer rather than why you are saying that infections. So that is one. And the other reason is if nothing works, then you need to do what is called urinary diversion. You see the last slide in my presentation, which is much more involved and a lot of potential complications. We don't do that unless the patient reaches a stage called end-stage bladder disease, where the bladder cannot be salvaged. And one of the other reasons, as I mentioned earlier, is the sphincter dyssynergia, which is very, very common. In those cases, it's very simple. You can give alpha blocker treatment, which relaxes the sphincter, so you don't need to keep doing the catheterization or indwelling or self-intermittent. So it's very, very important to know the cause and then attack the cause, and then use the antibiotics and then preventive treatment judiciously. Hope that will answer your question.
I'm going to take two really brief questions just so we dispense with them.
Okay.
They're very short.
Can I ask one question? Somebody just wanted clarification on the antiseptic that Dr. T had mentioned. Do you recall what the antiseptic was that you had mentioned?
It's called methylamine.
METHAGNAMINE.
Methylamine.
Okay.
It's one of the oldest medications used in the urinary problems. Extremely effective, very safe.
Okay. Now, Don, you're on.
No, thank you. Thanks for that clarification. Okay, just very, very brief. I recently heard about Guillain-Barré syndrome, a disease showing some similar syndrome to MSA. Are these two diseases related? The answer is, to the best of our knowledge, not at all. There's no connection. One's a disease of the central nervous system. The other one's a peripheral nervous system. One's an immunologic disease, and MSA is probably not an immunologic disease. So they're not connected in any way, although they could look similar. Then on the glial cytoplasmic side, the cell you showed, is that from an autopsy? The answer is yes. Those are usually autopsy. You could do a biopsy in a living patient and you would see the same thing. That's a safe thing to do. But we don't really do that because the disease in and of itself generally declares itself over time, so there's no need to do a brain biopsy.
All right, my turn. What's the age range of onset of MSA? Well, the average age at which it starts is in the mid-50s, like 55 or so, and the range, there's a huge, you can always find somebody who's going to be 20 years younger or older, but basically everybody is between about 50 or 45 and 65. Racial demographics, any prevalence of any particular race? No. unlike Parkinson's disease, where there seems to be far fewer black people, and Asians are intermediate between whites and blacks in terms of Parkinson's, MSA, there seems to be no racial predilection. And any male-female predominance, I think it's about 50-50, unlike Parkinson's, which is like 55% male.
I have a question. Dr. T, in one of your slides, you spoke about the sequencing of the MSA symptoms and speaking about urological symptoms predating the neurological symptoms. And my husband has MSA, was diagnosed 1.5 years ago, and has both urological severe and neurological and urological symptoms. And I saw on the slide you talk about when that's the case, there tends to be a rapid decline, which we have noticed. And I know with people, many times speaking with both caregivers and patients, people are trying to understand the progression of the disease and how it's different with so many people. Why is it that there's a rapid decline when that seems to be the case?
So in those cases, what happens, the clinical manifestation of the urinary symptoms takes some time. Already what happens, there is already some tissue damage already which has taken place, even though this patient will not experience symptoms for a few months or few years. So already there is some damage which is already done by the time the patient presents initially with the clinical symptoms. So that's the reason why there is a disparity between the amount of damage to the urinary tract and the severity of symptoms. They don't go hand in hand.
Okay, I'll take a couple of autonomic questions, or one at least. Here's one about, we didn't really cover bowel, and bowel is a very important issue for many patients. With autonomic failure, a major problem, why do neurologists tend to recommend more fiber, prune juice, and exercise? None seem to recognize that the anal sphincters and other bowel functions are just not working properly. So bowel management is indeed a challenge, and actually I have a family, my own family member who had Parkinson's disease, and the sphincters were actually surprisingly the biggest issue, not the motor manifestations and not low blood pressure. So this is a very difficult area, but it's somewhat manageable. You have to balance, so you have to keep motility moving. So there's two aspects to this. One is keeping the sphincters opening and closing, and the other is keeping the bowel motility. So the recommendations for prune juice, exercise, and fiber are really mainly to keep the bowels moving. One of the major things you don't want to get into is an obstipated state that we do see quite a lot. So if an obstipated state fundamentally means that you're beyond constipated, that in fact your bowel has become a rock, and you obtain a plain x-ray of the abdomen, you see the abdomen is absolutely filled with stool. And in patients with multiple system atrophy, this produces dramatic autonomic changes. And patients can actually look like they're declining rapidly, they're losing energy. It can become a major issue, and then you have to do a bowel clean out at that point. So keeping the bowel moving, I would agree with these recommendations. Keeping the bowel moving is very important, and I will often use a product called Miralax, and that's effective in about 80-90% of people. And you just regulate the amount of Miralax so that your bowels are neither too hard nor too soft. So the sphincter aspect is this aspect, is you don't want to overdo it, you don't want to underdo it. So if your sphincters are not working very well, meaning that they don't open easily, then you want softer stools. So you want your stools, so you want to have stools, and you can regulate that pretty carefully with the amount of Miralax you take every day, and combining that with fiber and exercise and other things. If your sphincters have trouble closing, then meaning that you have incontinence of stool, which also happens, then what you want to do is you want to regulate your stool so it's a little bit harder. Then there's a little trick. If any of you have a compounding pharmacy, you can actually have the pharmacy, you have to have your doctor prescribe this, but phenylephrine can be compounded into a cream. And that will cause the sphincter to tighten up for about 4 hours. So if you're going out somewhere and you have a problem with your sphincters constantly opening, and it's obviously socially very embarrassing, you apply the phenylephrine cream to the sphincter right when you're going out, and you can be pretty confident for 2 or 3 hours your sphincter will stay closed during that time. So that's the opposite of what we use for in the bladder for opening. So both the anal sphincter and the urethral sphincter have very similar properties. They open if you block the alpha system, and they close if you stimulate the alpha system. So what we're doing is just using a drug that stimulates the alpha system and keeps the anal sphincter closed. But just want to emphasize, I do agree with these recommendations despite the problem with the sphincters. You just have to regulate it yourself so it makes sense to you and works with how the sphincters are dysfunctional.
Okay. There's a few things here I can go through pretty quickly. Is there such a thing as a replenishment for melanin? The problem with MSA and the other Parkinsonian disorders is not that you're missing melanin, it's that you're missing the cells that make the melanin. So when those cells die, the melanin is just kind of floating around and gets reabsorbed by the system. Now, it's possible maybe that the melanin itself does have some kind of a chemical participation in the problem, but we don't have any way of replacing it in any case at this point. Next question. What medications are used for myoclonic movements of MSA? Myoclonic movements are these very rapid movements that sometimes people with MSA have. It could be the head, the body, anywhere. Sometimes they're very small. Sometimes they could be big enough that they're actually a disability. There's a whole family of drugs. Most of them are in the same class as Valium. They're basically muscle relaxants. There's one called clonazepam that's used a lot. And there's a drug called Keppra, which is an anticonvulsant that can also be used. So basically, it's muscle relaxant drugs. Can you describe the progression of MSA? Signs and symptoms of early and late. Well, there's no one answer to that. Everybody's different. It can start with any of the features that I mentioned in my talk and progress to the next one. Could be any of the features. There's just no predicting it. But I'd say if I could say something just as a blanket rule, it's that the dysautonomic problems are most likely to be the first ones, and the REM behavioral disorder. In a man, erectile problems are usually the first thing that happens very early on, years before, and the constipation as well, years before. And an example, a person in mid-60s with onset of sleep difficulties, stiffness, shuffling, and orthostatic hypotension. Well, the mid-60s is getting kind of late for MSA, and I'd say basically, based on just this information, I'd say that Parkinson's disease is more likely, but I don't want to be giving personal medical advice through a microphone here. Okay.
So after green light prostate surgery, will self-cath still be helpful with incontinence and retention? Before I answer that, I would like to know whether this incontinence of urine or retention is a complication of prostate surgery, green light prostate surgery, or is it because of MSA? The prostate surgery went well and the patient has MSA, and these problems presenting, urinary problems presenting as incontinence or retention. So I need to have the answer for this before I recommend anything to the patient. So the way I do that is I do two things. One is a urodynamic study, the other one is cystoscopy. So after prostate surgery, sometimes because of the heat which we use, the heat energy to resect, remove the prostate, can stimulate fibrous tissue reaction there in the region of the prostate, and that can cause scar tissue. So the urinary passages can become contracted, can become narrow, resulting in retention of urine. If that is so, that requires surgery, where we have to cut open the narrow area caused by the scar tissue. We have to remove the scar tissue. So that is a treatment for retention in those cases. For example, you do the urodynamics and you do the cystoscopy, the urinary passage is wide open, then I do the urodynamics. Then I see what is the reason for the retention. Is it a weak bladder? Then I would recommend clean intermittent catheterization or suprapubic tube or urethral catheter, whatever the case. Or, for example, the incontinence. The second part is incontinence. If there is incontinence after prostate surgery, then we have to see is during one of the complications of prostate surgery is damage to the sphincter muscle around the urethra. That can potentially happen. If that happens, I know that by looking at the urethra by cystoscopy, is in one of the pictures, or by urodynamics. If that is a reason, then I treat that patient by inserting a sling or an artificial urinary sphincter. But if this problem is not related to prostate surgery, then obviously I get the diagnosis by urodynamics and treat the patient according to what I find on urodynamics. And then the next question is, have you performed a simple cystectomy? And the answer is yes. Cystectomy is removal of the bladder for benign conditions. Usually we do that for cancer, bladder cancer. We remove the bladder and the tissues around the bladder. It can also be done, it is also done for some very specific conditions in the bladder itself. One of the conditions is called pyocystis. Pyo means pus, cystis in bladder. So pus inside the bladder, when the bladder it becomes end-stage bladder because of including MSA, any of the neurological problems, then if we keep the bladder inside the body, it can cause septicemia. So we remove that bladder. And sometimes some benign tumors, we remove that. And next question is your thoughts, can you combine the cystectomy with sigmoid colostomy? It can be done very well, no problems. It can be done by open surgery or by laparoscopic or robotic surgery. So there is no reason why both cannot be done together. So I think that answers.
Okay, my turn. If a patient is wheelchair bound, should they still be taking salt? And so the management of orthostatic issues is relatively straightforward. Just like in diabetes, you would be guided by the sugar level. In orthostatic hypotension, you're just guided by the blood pressure. So whether you need salt or not would depend on your blood pressure readings. Remember that salt is probably the most effective blood pressure raiser after water drinking. So we talked a lot about water drinking. The 8-ounce glass of water you take first thing in the morning that raises your pressure 40 millimeters of mercury. But salt is more effective than mitogen, more effective than fludrocortisone, and without salt, fludrocortisone and mitogen do not work very well. So you want salt to be sort of the basic element of your blood pressure management, and then you want to let the other drugs be added on as you need them. It's better to be on more salt and less mitogen rather than more mitogen and less salt. So say, for example, when you're sitting down, your blood pressure is 100/70. You really want to aim for a pressure of maybe about 120 sitting or so. That said, you also want to aim for a lying pressure that's not too high. So the guidelines that I use is about 200/100. Whatever you need to get a pressure that's about around 100, 110, 120 sitting, if you're no longer standing. I generally try to aim for a systolic of 100 in either the sitting or standing position, whichever position it is that you're assuming. If you're not assuming standing position, then we just worry about the sitting position. And whatever that takes then in a supine, you're going to have a high pressure supine to get that pressure to systolic 100. Remember the information I showed you about symptoms. So you will not know when you're lightheaded. Your pressure could be as low as 60. I was talking to one of the patients' family members who was telling me, well, my dad's neck is hurting a lot. That could be the main symptom of orthostatic hypotension, neck pain. So you want to measure blood pressure at that time. Don't let symptoms guide you. Let readings guide you. Let the blood pressure readings guide you. So if you've got a pressure of 80/60 lying, take salt. If your pressure is 140/70, I'm sorry, did I say lying? I meant sitting. If pressure is 80/60 sitting, take salt. If your pressure is 140/80 sitting, of course you don't need salt. So let the numbers guide you, and use as a guide that your lowest systolic pressure should be about 100. 100 people do very well.
I think Vera has a question.
Somebody wanted to know, it says, I hear about Botox used with MSA. How does that help the bladder or other areas?
Yes, Botox is used, yes. What was the question?
that help the bladder or other areas?
It helps the bladder by improving the overactive bladder symptoms, which are frequent urination, urgency, and sometimes the patient can leak urine if the problem is severe. So that is a very, very well treated by botulinum toxin, especially when it is not responding to the medications. You can also use this botulinum toxin off-label, not approved, for a patient with dyssynergia, where there is a sphincter muscle below the bladder is spasmodic, and it is preventing the effective emptying of the bladder, where you inject the medication into the muscle, so the bladder can empty normally. So that can be used, but again, that is off-label. But the initial indication for overactive bladder, neurogenic overactive bladder, which is common in MSA, if it is refractory to the medications, is the botulinum toxin is approved.
This is for Dr. Globe. I'm Tommy Gillard, and I really appreciate your comments on the stem cell research. I certainly understand what you're talking about in terms of drug delivery, but the piece I don't understand is when you state that we could introduce blood cells or stem cells and they would create new neurons. I guess where I'm questioning there is if we have dysfunction in our brain, proteins unfolding, don't we have to cure the dysfunction, or they're just going to eat those brain cells, right up?
You're touching on a very important concept that you all have to understand when you talk about curing a disease. Curing a disease means two things, two separate things. One is to stop the ongoing progression of the process, and number two is to repair the damage that's already been done. And what stem cells, the nearest of those two for stem cells is stopping the progression by delivering some drug that might interfere with some biochemical process that's driving the degeneration. Okay, so for example, if we figure out why the proteins are misfolding, there might be some process in there where you could throw a monkey wrench into that process by delivering some drug, and maybe stem cells are the little factories, the drug delivery systems that will do that job. So that's number one. And number two is replacing what's already been lost. And that is a lot more years in the future, unfortunately.
I have a two-part question. Second for Dr. Cheminsky, please. You mentioned about Parkinson's and extreme exercise. I live in Alexandria, Virginia, and posted an article on a gentleman that is an avid rower, like half the day, and then he spends the other half the day with the trainer in boot camp. And the amazing results that he's had through this. He's never had to take any Parkinson's medication, blah, blah, blah. And supposedly NIH was going to start a trial based on, very extensive exercise and its effect on neurodegenerative diseases. Personally, from the very start when I was diagnosed, I figured just keep moving, just keep moving. And I spent a lot of time trying to do that just so I can walk, Can you kind of give me your thoughts and expand on that? One question I do want to know is, I really push it to the point, for example, I have to be holding on to something because of my balance when I'm on the treadmill or the elliptical. I'll do like an hour on the elliptical at the highest. I get off, I have to sit in the gym and like milk it by wiping down the machine and looking at the TV before I take a step and fall down, So that takes me about 5 minutes. So I'm curious as to your thoughts there. But I'll tell you one last thing. I feel great when I walk out.
Yeah, so Amy, are you going to talk about exercise? Okay. Okay.
I'll be talking a lot about exercise. You're right. In the area of Parkinson's, I'm a physical therapist. I'll be talking in the afternoon. In the realm of Parkinson's disease, yes, they're doing a lot of research right now with forced exercise, forcing the person to go faster than they volitionally can, for example, listening. then as far as, exercise concerns in MSA, we're going to be talking about that this afternoon. But you're right, moving is good. But then, yes, there are the questions of what is overdoing it. So we'll talk to that.
Okay, good. I just want to say from a neuroscientific perspective, the effects of exercise are completely, are mostly haven't been studied enough. I mean, so there are just dramatic changes in various types of receptors, cannabinoid receptors, activation receptors, various nuclei in the brain change shape with exercise. Even in the spinal cord, there are changes in what we call the dendritic patterns. So exercise is a very untapped methodology, and I think we're going to see a lot coming out in the next 10, 20 years.
How are we doing on questions?
We've got a few more here, some simple ones. Here's a.
I think Vera has one more, and then we're going to need to wrap it up because I know you guys need to leave, and that was a promise I made that I've broken already.
Okay.
It's
Well,
a little
here's
after 12, but
here's some very simple ones. Have you ever seen MSA affect one side over the other? Absolutely. Asymmetric presentation of both Parkinson's disease and MSA are common. You correct me if I'm wrong, but I think in general, Parkinson's disease can be more asymmetric than multiple system atrophy. Generally, there's some symmetry to them, and there's another question, does the cerebellum favor one side? No, it doesn't favor one side, but the asymmetry of the disease can certainly affect one side more than another, and that's not uncommon. Does MSA affect mental judgment or mental responses? That's one of the areas that's really spared in MSA until very, very late. In the slide Dr. Golby showed, it showed you that I think dementia was the very last thing. In order to find dementia in MSA, you really have to do careful studies. It does affect the brain, there's no question about it, but not in an everyday kind of way, in the way that a person starts forgetting or is not able to function or not able to write checks. Usually it's the motor manifestations and the sphincter and autonomic manifestations, not the mental manifestations, that cause problems in MSA. Is it possible that Agent Orange caused MSA? That's a very interesting question. That was looked at by the epidemiologic study that the late Cliff Schultz ran. And there is it's just like the genetics. There's sort of this connection. There was thought to be a connection with well water at one point, maybe. There's also a connection with pesticides. And is there a connection with Agent Orange? It's just like the alpha-synuclein gene. You throw that into the pattern, it makes you just ever so slightly more likely to get it. But I don't think we could ever say it's a cause.
Question about how you diagnose MSA relative to PSP, how you differentiate them. That's a pretty complicated answer. It's kind of more of there's no real cut and dried ways. I mean, there are diagnostic criteria for both diseases, but inevitably a lot of people will fall in the cracks. And it very often is hard to tell the difference. And that's why a big treatment trial in Europe from a few years ago that was testing riluzole wanted to test it in PSP, and they figured, well, we can't really tell MSA from PSP, so we'll recruit people with both diseases into the same trial. And they tested both diseases together as one big group. Unfortunately, the drug didn't work. And the second part of this question is, what about a DAT scan in diagnosis? A DAT scan, DAT, stands for dopamine transporter. This is a type of scan which has been available in the United States about for the past year. Most large hospitals have it now. It's a test for dopamine brain cells, dopamine neurons. It just shows up the dopamine neurons as a blob on each side of the brain, and the blob is smaller if you have loss of your dopamine neurons. And you get the same kind of loss, pretty much, in Parkinson's and MSA and PSP. So you can't use that test to differentiate between those. The value of the DAT scan is in somebody with a tremor who might have benign essential tremor, which is not a loss of dopamine neurons. You can differentiate that from Parkinson's disease. Or looking at somebody who has Parkinsonism, the appearance of Parkinsonism from taking strong tranquilizers. You don't have loss of dopamine neurons in that, so that's another use of the DAT scan.
I'll just say one thing. If there's one test that can help you differentiate Parkinson's disease from multiple system atrophy, I would say it's probably what's called MIBG scanning of the heart. That's probably the best way to, if you really need to make the distinction. And even that's not perfect by any means. But it's probably better than autonomic testing. And by the time the imaging, the MRI shows the changes that Dr. Goldby showed you, the clinical diagnosis is really evident, so that's not that useful.
Should the light switch be on or off to have a better bladder control? So probably this relates to my first slide where you saw the turn on, turn off switch. So basically, it should be both. It should be turned on when it is necessary, turned off when it is necessary. So it can't be on all the time or off all the time. So by that, what I meant was, the parasympathetic supply, which supplies the bladder muscle to make the bladder contract, it should be on when you want to empty the bladder, but it should not be on when you want to, relax. So during the filling phase, where the urine fills the bladder, it should not contract. It should be off. During the voiding phase, when we urinate, it should be on. Same thing. The sphincter, then blood and the nerve supply to the sphincter should be on, so that the sphincter is contracts when you're sitting and listening to me, or when you are you want to empty the bladder, so the sphincter muscle should relax, so it should be off. So you should have a balance between on and off of all the muscles in the lower tract. That's one. And
we have one from the floor.
This is kind of a qualification question for neurology and for urology. Are neurologists qualified to suggest urology type treatments? Yes. Like, for example, my mother has MSA, and her urologist has said that he does not want to be involved in the late stages of MSA because he doesn't know enough about it. She has an indwelling catheter, and we're not sure if that's helping, if the infections are too many, or he said that she needs to be referred to just the neurologist, basically.
So traditional American medicine, everybody's going to silo, and it's just not going to do the job. And basically what you need is you need to get them to talk to each other. So you tell the urologist, look, the neurologist needs you, and tell the neurologist, the urologist needs you. And they have to talk to each other and come up with a plan that'll be much better than either one alone.
Thank you.
And, there are a lot of places in the country, in New Brunswick, New Jersey, the medical mecca of the world, we're lucky to have a neurourologist and a movement disorder neurologist who work together. But very few places are that lucky. Well, this is what referral centers are for. I mean, places like the Mayo Clinic, they make their living on patients who come from medically underserved areas. I'm not talking about third world countries. I'm talking about places where, a medium-sized city where you don't have a urologist who's interested in really tricky urological problems. And such people go to places like the Mayo Clinic, or maybe if you're in Connecticut, the Leahy Clinic, not too far away, where there are facilities. There's a hotel where patients' families can stay overnight while the workup and the treatment are being accomplished. So it might be worth the sacrifice of making such a trip.
I think probably the last question. What is the name of uriniotomy test? I don't think there is any test by that name, but probably I think it's a urethrotomy, if you meant whoever has given this question. Urethrotomy.
Or maybe
Otomy, yeah.
Cystoscopy?
So otomy is like cutting. So it's a name, otomy is cutting. When there is a scar or narrowing, we cut it open. So it's called urethrotomy. When there is a stricture, we cut it. Or if it is a cystoscopy, if that is what you meant, it is looking inside the bladder and the urethra to see is there any problem, any narrowing or enlargement of the prostate, or any stone in the bladder, any tumor in the bladder. That is cystoscopy. Urethrotomy is a treatment. Cystoscopy is a diagnostic test. The other one is uroflowmetry, where we see how the patient is urinating to have an idea how his bladder is working, or urodynamics. So these are the terms, but I think probably there is nothing like uriniotomy, so urethrotomy.
Any more questions up at the table?
Oh, I think yeah. I think this questioner here, the answer is Urodynamic Study. The overall testing thing where they look at the flow and whether there's too much urine in the bladder, whether there's an obstruction, urodynamics.
Yeah.
Is that it?
Yeah.
Okay. I guess the old saying is better to ask for forgiveness than to get permission ahead of time to keep you guys past 12 o'clock. But let's have a big hand for our expert panel. So, Dr. Golby, the local guru here in town on neurology, Dr. Thomas Schleminski from Wisconsin, who sits on our board of directors, and Dr. T, who you've just learned everything you ever wanted to know about the bladder. So we really, really appreciate their being with us today, as we appreciate all of you coming and hearing what they have to say, because they donate their time. So your applause is their payment, trust me. So we do appreciate it. So, okay.